Hello, everyone, and welcome to Race, Equity, and Health Policy. My name is Sarah Vidrine. I'm the Health Policy Specialist at NC Child, and I'll introduce our speakers in just a moment, but before I do, just have some quick housekeeping and instructions for everyone. If you've attended the sessions previously, you have heard this before, but for folks who are new, this session is completely bilingual in English and Spanish. We have a live interpreter on the line, and everyone will need to choose either the Spanish or English channel to hear the audio. If you do not choose an audio channel, you will not be able to hear the presenters. So look for the little image of a globe and the word interpretation at the bottom right of your Zoom screen. Click on that globe icon and choose either Spanish or English. If you choose the Spanish channel, you'll hear the interpreter speaking in Spanish. You will also be able to hear the English language presenters at a low volume in the background. If you do not want to hear English in the background, you can click that globe icon again and choose mute original audio. The instructions for this are also in the chat. We have a lot of participants in all of the webinars today, so we're going to try to keep everybody on mute to preserve audio quality. One note, this session was recorded ahead of time, so you're about to see a video of the presenters, but they are both here live with us now, and we'll be able to take your questions in the Q&A box and chat with you throughout the presentation. I believe the presentation will take us right about to the end of our time together today, so we probably won't have a lot of time for questions and discussions following the presentation. So please do go ahead and type your questions in the Q&A box at the bottom of your screen throughout the presentation, and both Tanya and Sarah will do their best to answer those. Please use the Q&A box for the questions. You can use chat box for general comments to communicate with me or other staff, anything about technical difficulties, etc. And just a disclaimer, the opinions and perspectives expressed by today's presenters are their own. And finally, this session is being recorded. So the video will be available over the next week or two in both English and Spanish. We'll send you an email when all the recorded sessions are available. Okay, let's get started. It is my pleasure to introduce our speakers today. Tanya Bass is a program supervisor at the NC Office of Minority Health and Health Disparities and the founder of the NC Sexual Health Conference. Sarah McCracken works as a project coordinator for the Women's and Children's Health section in the NC Division of Public Health. And at this point, I'm going to go ahead and share Sarah and Tanya's pre-recorded presentation with you now. Just let us know in the chat if you're having any trouble hearing.
Hello, everyone. This presentation will be on racial equity in health policy. My name is Tanya Bass. I'm the Cultural and Community Initiatives Program Supervisor for the North Carolina Office of Minority Health and Health Disparities. And my co-facilitator today is Sarah McCracken, SSDI Project Coordinator in the Women and Children's Health section of the division, in the North Carolina Division of Public Health. Today, we're going to talk to you about racial equity in health policy. The agenda for this conversation will begin with a pecha-kucha, which is Japanese for chit-chat, to really ground us in understanding health equity. We will then review some terms and definitions, talk a little bit about and give an overview of the health equity impact assessment process, and then share some lessons learned. First, we'll begin with our pecha-kucha. North Carolina has made significant strides in advancing health equity and decreasing health disparities, but there is still more for us to do. We believe this training today, with continued discussions, will help us to do what is right to ensure that all levels of our division are invested and fully apply health equity lens to fund, support, plan, and implement programs and services. The history of North Carolina and the United States strongly impact what we do. The lived experience of our citizens is the most important narrative influencing health equity. We have to acknowledge this history and the narratives within our community so that we are careful not to repeat the mistakes of the past. Health is essential for children to learn, employees to work, and communities to thrive. Many of you already know that a child born in Pittsboro, North Carolina, is expected to live 10 years longer than a child born just 89 miles away in Lumberton, North Carolina. Social inequities such as poverty, segregation, and a lack of educational and employment opportunities have been rooted in discriminatory laws, policies, and practices that have historically denied marginalized populations, especially people of color. What we do in our division can make a difference so that every child, every person will have a fair and just opportunity to be healthy. The narrative of health disparities and equity can be changed, and those closest to the pain are typically closest to the solution. We have to acknowledge that every day, everybody, everywhere in North Carolina public health are not experiencing good health. If we believe that health equity means that everyone has a fair and just opportunity to be healthy, we have to remove the obstacles to health by examining our internal processes and processes and create strategies that actually work. Many of the DPH staff do not come from backgrounds or have had academic preparation or even life experiences to understand the impact of oppression, social exclusion, or marginalization. These are the things that hinder groups and create barriers based on skin color, national origin, religion, wealth, disability, gender identity, from fully participating or sharing the benefits and participating in society, including good health. These groups tend to have less power and generally less wealth. For many of you, this may appear to be one more thing to do or to think about, or it's not a priority based on your current workloads, or you think will never hit the mark of health equity. Therefore, this framework is important because it will require us to think about the things we typically do not acknowledge, including the areas of our privilege in our lives and in our organization. Advancing health equity requires identifying and addressing not only overt discrimination, but also unconscious and implicit bias, and the discriminatory effects of unintended and intended structures and policies created by historical injustices. Even when conscious intent to discriminate is no longer clearly present, health equity means assessing every area so no one is left behind in our current programs and policies. Our approach to health equity should build and optimize on the existing strengths and assets of those marginalized. Ultimately, our work should benefit everyone's well-being, with a focus particularly on those with the worst health and fewer resources to improve their health. Equity is not the same as equality, and those with the greatest need and least resources require more, not equal effort and resources to balance those opportunities. These efforts take nothing from those with greater resources because their needs are different. Some communities prosper with rich health environments while others face deep structural barriers that make it difficult to be healthy. If we're serious about eliminating unfair, preventable differences in health outcomes, we must eliminate the unfair conditions that give rise to them in the first place, and at best, acknowledge those conditions and let them shape our work at the forefront. This will require meaningful changes, not only in the programs and individual attitudes and practices in our agency, but in the policies, the laws, the systems, and the institutional practices that keep social inequities in place, leading to health inequities. Remembering that there are no single issues, social justice, reproductive justice, racial justice, environmental justice, gender justice, and economic justice are all connected and must be addressed together. We should acknowledge that equity is more than one single intervention. For example, what's happening in Flint, Michigan is not just about environmental justice. Piecemeal approaches targeting one factor at a time are rarely successful or sustainable. Successful approaches to health equity should address multiple factors to eliminate and reduce obstacles to health equity. This requires accountability from all levels of leadership. The reason we aren't succeeding in health equity is because we are working in silos and everybody is doing their own thing. Even when you look at your work and you find that you've been successful, if there's one person or one group who hasn't gained health, then we still lose. There's no way to win if we all don't win. Health equity means everyone wins. We must work together to use health equity as a lens to inform our policy and program decisions. This starts with active support from our leadership. Your support and your vision can foster the efforts to strengthen our communities and eliminate barriers to good health. Framing health equity is a continuous process. This is not a one-and-done situation. The pursuit of health equity is never finished. It requires constant, systemic, and devoted effort. A sustained commitment to improving health for all, particularly those in most need, is an essential part of what we do. This work will not be comfortable, or will it be easy? We've come to this work with different drives, goals, and perspectives. We will not need to conform in order to achieve agreement, but we must value the differences and create opportunities for health in a way that benefits everyone. So today, during this training, let's begin to make a more collaborative effort in accountability, challenging assumptions, maintaining a community focus, and adapting to new ways to providing services. We can use the health equity framework to create a better understanding, common language, and guide to advance health equity. So hopefully hearing that, you can have a better understanding of health equity and what it looks like and what it could look like in the future as we advance health equity. Now we'll talk a little bit more about the terms related to and the definitions related to understanding, addressing, and advancing health equity. So our first term is really, or terms, will be having an understanding of equality versus equity versus liberation. So if you look at this image, and many of you have seen these images before, when we look at equality, what we know is that everyone gets the same thing. As you can see in this image, everyone has been provided a box so that they could potentially see this baseball game. But what we note is there's still some people who don't have what they need. Equity, on the other hand, means that everyone gets what they need in order to be successful. So here you can see one individual doesn't even have a box because they don't need it, and they can still access and have the ability to see the game, whereas another individual may have 2 boxes. What we're striving for overall is liberation, where there aren't any barriers to accessing and attaining what we actually need. Furthermore, the Robert Wood Johnson Foundation offers up this imagery to demonstrate the same thing. So here at the top, you see equality. So in this particular image, if folks want to enjoy riding a bike, everyone was provided the very same bike. But as you can see, one has issues with access or accessibility. The other is not very comfortable. One person seems to be comfortable, and then the first person doesn't seem to be comfortable either. The bike looks like it's too big. One's too big, one's too small, one can't ride at all. But when we think about it from equity, equity means everyone has the opportunity to enjoy bike riding. So they have the bike that they need to participate in this activity. We think that this imagery shows, although it's not perfect, but it still gives a good definition and imagery of what equity actually looks like. So now we're going to ask you a few questions. Quiz time. So which of the following do you believe is the definition of health equity? A, giving everyone the same resources. B, the opportunity for everyone to have good health. C, measurable differences in one's group health over another. D, conditions in which people are born, grow, work, play, and age, and the wider set of forces and systems shaping the condition. And then E would be none of the above. Give you a few minutes. Hopefully, based on what we just discussed, you were able to select B, the opportunity for everyone to have good health. Let's try another one. So which of the following are examples of social determinants of health? Income and employment, housing and education, social support, leadership, political influence, or E, all of the above. I'll give you a few minutes to make your choice. All right, let's check out that answer. Hopefully you said E, all of the above. What we know about the social determinants of health, it includes all the things of where we live, work, and play. It includes our income and ability to attain and maintain employment. It includes housing and education and access to housing and education. It includes those social supports, both internal and external to our community and families. It also includes leadership, both on the political level and on the community level. So all of the above would be the correct answer. Our next question, which of the following is the definition of environmental justice? A, personal steps to advocate for the environment, including recycling and reducing our carbon footprint. B, fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policies. C, communities providing sidewalks and fluoridated water. D, equal distribution of wealth, opportunities, and privileges within a society. And E, behavior or treatment that is just. Now, this is environmental justice. So what do you think? Hopefully you noted that environmental justice is fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policies. Now, what we do want to know is that health equity is social justice in public health. And when we think about social justice, that is the equal distribution of wealth, opportunities, and privileges within a society. So overall, when we're looking at health equity, we're really trying to advance social justice, but from a health perspective. Here's our next question. Which of the following best describes inclusion? A, inclusion is involvement and empowerment where the inherent worth and dignity of all people are recognized. B, an example, Esmeralda, a woman with cerebral palsy, started working in a local office after graduation, where she goes for lunch and after work outings with her coworkers. C, inclusion applies to all parts of life. Or D, all of the above. Give you a few minutes or seconds. All right. So D, all of the above. So when we think about Esmeralda, someone who's differently abled, has some limitations, but she was able to get employment at a local office after she graduated, and she's able to go to lunch and enjoy the company of her coworkers. Also, inclusion means the involvement and empowerment of everyone, where the inherent worth and dignity of all people are recognized regardless of their ability status. So some of the other terms and definitions we want to leave with you today is having a better understanding of health disparity. So health disparities exist when we have the differences in health status between people that are related to social or demographic factors such as race, gender, income, and geographic region. We see that health disparities are things that continue to be perpetuated even currently as we look at COVID-19. What we want to do and what we believe is addressing and advancing health equity will mean eliminating some of these health disparities. Health equity is the absence of avoidable and remediable differences allowing for the attainment of optimal health for all people. Remember, health equity means that everyone has the opportunity for good health. And then what we'll be talking to you a little bit more today is the health equity impact assessment, a tool that enables decision makers and policymakers to intentionally focus and align strategies and policies to reduce health inequities. The social determinants of health is what we mentioned earlier. The conditions in the places where people live, learn, work, and play, and how they affect a wide range of health risks and outcomes. Inclusion meaning that all people, regardless of their abilities, disabilities, or other social identities or healthcare needs, have the right to meaningful participation in work, school, and the social community. And of course, revisiting environmental justice, fair treatment, and meaningful involvement of all people, regardless of race, color, origin, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policies. So here, we'd like to offer up Dr. Kamara Phyllis Jones, who's the past president of the American Public Health Association. Dr. Kamara Jones has a really good way of providing allegories or analogies, helping people to better understand how racism, and providing this theoretic framework of how racism shows up in health, not just in health, but in the world, but how it impacts health. So at this time, we're going to take a few minutes to look at her or listen to her explain one of the allegories, in particular, the Gardener's Tale. So bear with me as we go to that video. We're hoping that this video will provide you more insight on how health is impacted by race and issues surrounding the many aspects of racism.
Measuring and addressing the impacts of racism on the health and well-being of the nation. But what I'm going to do today is empower all of us with tools for communicating about race and racism. I see the world in allegories. Sometimes I just look at an ordinary situation and I get some insight about how to communicate about very complex ideas. So today I'm going to share with you 4 allegories on race and racism that I hope you will understand, remember, and then pass them on. The first story, Japanese Lanterns, Colored Perceptions, was sparked by my own real experience back in the day when I was at this very nice garden party in the evening in California. And I had my turn with chitting and chatting, and I was just sort of tired, and I wanted to just sit back in the corner of the garden and relax and listen to the conversation and music just wash over me. And as I sat there in the garden, I became fascinated by a group of pink moths. And then I looked a little further on and I saw a group of green moths and a group of blue moths. And so not only was I fascinated by that, I was fascinated by how they naturally were sorting according to their kind. And then I looked over my shoulder and I saw, wow, and there's some yellow moths and some purple moths and some orange moths too. And the scientist in me was getting very excited about this until I was like, oh, of course. There is no such thing as purple or pink or blue or green or yellow or orange moths. Moths are different colors, yes, but they're different colors of brown and tan and speckled and splotched. But the colors that I thought I was seeing and the colors that we think we see every day are actually due to the lights by which we look. These colored lights distort and mask our own true variability, which can only be seen under a universal light that allows all possibility. So when I remembered this image, I started thinking, what is race? And how do the racial categories that we construct color our imaginations of who we are? And in my mind, race is clearly a social classification, not a biological descriptor. It is the social interpretation of how one looks in a race-conscious society. So here in Atlanta, in the United States, by the colored lights that we look at, I'm clearly black. But in some parts of Brazil, with different colored lights, I'm clearly colored, clearly white, actually. And in South Africa, I'm clearly colored. And so we need to challenge ourselves to understand the impact of these different colored racial categories that we construct and how it's limiting our understanding of our own true variability. The second story, Dual Reality, a restaurant saga. This was also from my time back as a medical student in California. And I had been studying with some friends. It was getting late. We'd missed dinner. And so we went into town to get something to eat. And we walk into a restaurant and we sit down, we order our food is served, and here we are eating. And that's not remarkable. Many of you have had that experience. And I wouldn't have thought anything more about it or be talking about it today, except that I looked up and I noticed a sign. And that sign was provided me a profound insight about racism. So what did the sign say? The sign said open. Now, I could have thought nothing more about that, right? I was sitting at the table of opportunity, eating, with a sign that proclaimed open to me. But because I knew something about the two-sided nature of those signs, I realized that in fact, people who were hungry but just a few feet away from me on the other side of the sign would not be able to come in because in fact now the restaurant was closed due to the hour. And I realized that racism and other systems of inequity structure open-closed signs in our society. And it's important for us to know something about the two-sided nature of these signs. It's important for us to understand how these signs, how racism and all of the other isms create a dual reality, where on one side, people who are in the side, for any of us, it's difficult for us to recognize any system of inequity that is privileging us. So, for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white people in this country to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the world context. Yet, for those on the other side of the sign, they are very well aware of the two-sided nature of the sign, because it's proclaiming close to them, and yet they can see through the window and see that people are eating on the other side. So back inside the restaurant, I understand that people might ask, does racism really exist? Is there really a two-sided sign? Because in fact, it's hard to know when all you ever see is open. It's a privilege, in fact, not to have to know about the two-sided nature of the sign. But once you do know, you can act. You don't have to act, but you can choose to act, and the knowledge about racism and its continued existence and profound impacts on the health and well-being of the nation is actually empowering. The third of my, let me just, before I get off of that, now provide you with a definition of racism that evolves out of this understanding. And I'm really clear that racism is a system. It's not an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested. But it's a system of power. And a system of doing what? It's a system of structuring opportunity and of assigning value. And on what basis is that opportunity structured? And on what basis is that value assigned? It's based on the social interpretation of how we look, which is what we call race. And what are the impacts of this system of power? Well, it unfairly disadvantages some individuals and communities, but it doesn't take very long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that it's also unfairly advantaging other individuals and communities. And then even as it's unfairly disadvantaging or advantaging individuals and communities, this system is sapping the strength of the whole society through the waste of human resources. My third story, Levels of Racism, A Gardener's Tale, comes from my experience when my husband and I, newlywed, bought our first freestanding house with a big wraparound porch with flower boxes all along the porch. Now, when we went to plant our marigold seeds, we saw some of the boxes had dirt in them and some of the boxes were empty. So my husband dutifully goes to the gardening store and he's hauling big old bags of potting soil, and we fill up the empty boxes and we put equal numbers of seeds in all of the boxes. And we water all of the boxes. And I'm not the gardener, so I sit back, just going to enjoy. And 3 weeks later, I walk out of my front door and I stopped in my tracks, because it looked to me like we had planted completely different species in some of the boxes versus others. In some of the boxes, they were full of plants, tall and vigorous looking plants, and other boxes just had a few plants in them and they were scrawny and scraggly. And then I realized what had happened. That potting soil was rich, fertile soil, so that in the potting soil, every single seed had sprouted, with the strong seed growing very tall and vigorous, but even the weak seed making it to a middling height. But in that old soil, that poor rocky soil that we had found there, the weak seed had died, and even the strong seed had to struggle to make it halfway up. And if you guys garden, well, maybe you've composted half of your garden and you've seen the same thing. This image is about the importance of the soil, the importance of the environment. And I'm going to make it a story about racism. But before I do that, I want to talk to you just a little bit more about racism, because in the story, I'm going to illustrate 3 different levels of racism: institutionalized, personally mediated, and internalized. And so, you know, sometimes I have an hour to talk about these things. I don't today, but I'm just going to quickly define each of them, make some important points, and then share the story. Institutionalized racism, what is it? It is that system that results in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that doesn't require an identifiable perpetrator. This is the kind of racism that's been institutionalized in our laws and our norms, and actually often shows up as inherited disadvantage. These are some examples of how it can impact you. Sometimes people look at my top bullet of housing, education, employment, and wealth, and they ask, isn't that social class? why you have this on a slide about racism. To which I respond, it doesn't just so happen that people of color in this country are overrepresented in poverty, while white people in this country are overrepresented in wealth. That's not just a happenstance. But for each marginalized, oppressed, stigmatized group, there's been some initial historical injustice. So for American Indians, for example, it was the taking of the land and the genocide, and then the moving of the survivors to the reservations. For people of African descent, it was the kidnapping of West African people, and then our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then people stop me there and they say, well, you know what, Dr. Jones, you're talking about slavery. But the enslaved people were emancipated by 1865, and that's fully 149 years ago now. So all else being equal, don't you think the impacts of slavery would have washed out by now? But the key phrase there is all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are still what I describe as contemporary, present-day structural factors that are perpetuating the initial historical insult. And so when people ask me, am I talking about racism or social class, I say that institutionalized racism explains why we even see an association between social class and race in this country. Before I get off of this, I need to also say that institutionalized racism can be through acts of doing as well as acts of not doing, and often shows up as inaction in the face of need. The second level of racism, personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So here now we're talking about what most people think of when they hear the word racism. Somebody did something to somebody. It includes the prejudice and the discrimination, lots of ways that it can impact your health and your whole well-being. And like institutionalized racism, it can be through acts of doing as well as acts of not doing, but even more important, it can be unintentional as well as intentional. You don't have to intend it to have a racist impact, to do something racist to have a racist impact. Third level of racism, internalized racism, I define as acceptance by members of the stigmatized races of negative messages about our own abilities and intrinsic worth. Lots of ways that it can affect us, and it's really about accepting the limitations to our own full humanity of the box into which we've been placed. So now, with this background about what I describe as these three levels of racism, let's go back to this story. So here I have now 2 flower boxes. But what we're going to introduce is a gardener. A gardener who has 2 flower boxes, one which she knows to have rich, fertile soil, and one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the flowers are going to produce pink blossoms, and some of the flowers are going to produce red blossoms. And this gardener prefers red over pink. So what does she do? She takes the red seed and she puts it in the rich, fertile soil, and she takes the pink seed and she throws it in the poor, rocky soil. And 3 weeks later, she sees in her garden what I saw in mine. In that rich, fertile soil, all of the seed is sprouted. The strong seed has grown very tall and vigorous, but even the weak red seed has made it to a middling height. In the poor, rocky soil, the weak pink seed has died. And here comes the strong pink seed, just trying to make it halfway up. And then those flowers go to seed. And the next year, the same thing happens. And then those flowers go to seed. And then year after year after year after year, the same thing happens until finally, 10 years later, the gardener is looking at her flower boxes and she says, you know, I was right to prefer red over pink. So we're going to interrupt the story there for a minute to say that this first part of the story tells us something about institutionalized racism, where you have the initial historical insult of the separation of the seed into the 2 types of soil. You had the contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. But okay, well, let's pick the story back up. Where is personally mediated racism in the garden? Well, now the gardener is looking at red, thinking that red is mighty beautiful. She looks over the pink flowers and she says, oh, they sure are scrawny and scraggly. So she plucks off the pink blossoms before they can even go to seed. Or maybe she sees that a pink seed has blown into the rich, fertile soil and she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that still goes on. And where is internalized racism in the garden? Well, the red flowers who just living their lives, enjoying being read, many of them not even understanding that they're benefiting from enriched soil. The pink flowers are looking over at red, wishing with all their hearts that they too could be red. And here come the bees, minding their own business, collecting nectar, but of course pollinating at the same time. So here comes a bee, bzzz, and then up to another pink flower, bzzz, and then it comes toward this other pink flower, and that pink flower says, "Get away from me, bee, do not bring me any of that pink pollen. I prefer the red," because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in the garden? Well, let's start with addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink, right? And that's an important intervention. That's an important intervention, but as you can see, even if you do that, that's not going to change the situation in which they find themselves. Or maybe you say, okay, let's deal with the personally mediated racism. So let's have a conversation with the gardener, or better yet, let's have a workplace multicultural workshop for the gardener. It's all good. So we have our workshop, and in the workshop we say, "Dear gardener, would you please stop plucking those pink flowers?" And maybe she will, and maybe she won't, right? But even if she does, it still won't change the situation in which they find themselves. I think that if we really want to set things right in the garden, we need to address the institutionalized racism, which means we have to either break down the boxes and mix up the soil, or if we want to keep separate boxes too, that's all right too, but if we do, it means that we need to enrich that poor rocky soil until it's as rich as the rich fertile soil. And when we do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious as the red. And in that intervention, we might also address the internalized racism. Pink will no longer be looking over at red, thinking red is better, or wanting to be red. And in that intervention on the institutionalized racism, we also might address the personally mediated. Now, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful will be less likely to have that kind of attitude. So, in this story, I've actually illustrated these three levels of racism: institutionalized, personally mediated, and internalized, and very strongly suggested that if we want to set things right, we have to address the institutionalized racism. Good if we address all the levels at the same time. But the most important question is one that I haven't raised yet, and that is, who is the gardener, right? Because the gardener is the one that I gave the power to decide, the power to act, and control of resources, which in my mind are the elements of self-determination. Well, who is the gardener? The gardener clearly includes government, as well as media, as well as foundations and corporations, and even communities to the extent that they have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink, right? And it's also dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, because she's not even really keeping the pink flowers as part of her garden. And our challenge is what to do about the gardener. Do we make the gardener striped or polka dotted or fuchsia? Lots of different questions that can come out of this story. But I'm going to close in this last minute with one last image. And this image is not from my own real experience, but actually this is an image taken from the book by Dr. Beverly Daniel Tatum, Why Are All the Black Kids Sitting in the Cafeteria? And Other Conversations About Race. And in that image, she presents racism as a conveyor belt on which people are just living their ordinary lives, not really understanding that they're moving to and through racism, but just living their ordinary lives and contributing to racism by their benign inaction. So I'm going to build on this story, get back on the conveyor belt over here, to help us know how can we act. So here we are on this crowded conveyor belt, and we're just living our lives, most of us not even paying attention or even wondering where we're going. But say one of us looks up and we see racism. Well, one reaction is to close your eyes. That's denial, right? Or another reaction is to turn around. You're still going in the same direction. Maybe you're colorblind. But if we do not, and you know what that shows you? That shows you that racism is most often passive, most often shows up as inaction in the face of need. But if we're on this conveyor belt and we don't want to go there, then what we have to do is start walking backwards, right? And we need to walk at least as fast as it's going, not to go that way, but now we have to start walking faster if we don't want to, we really want to get away from that. And what happens when you start walking backwards on a crowded conveyor belt? You bump into people and they say, hey buddy, watch out. you going? And this is your opportunity to do the first of 3 steps in terms of being actively anti-racist, and that is to name racism. You say, look, do you see where we're going? Do you want to go there? And most people will say, just stop bothering me. But maybe 1 or 2 will turn around with you. So now you're 2 or 3 walking backwards on this conveyor belt. And now where are you headed? You're not just going away from racism, but now you're actually going to understand the conveyor belt motor. And now you're going to do the second of the 3 stages of anti-racism, which is to ask, how is racism operating here? And so maybe one of you thinks it's a lever, and you pick the lever up, and the belt jolts because the lever is part of it. But it's a very smart conveyor belt, so it reconfigures itself and keeps going. So now you have to do the third thing to be actively anti-racist, which is to organize and strategize to act with others who are on the other side, trying this dial or trying this button. And I believe that we together can dismantle the system and put in its place a system in which all of us can know our full potential and have the opportunity to develop to our full potential. So I have shared with you 4 allegories. Japanese lanterns talks about race as a social construct. Dual reality illustrates racism as a system that creates a 2-sided sign, a dual reality. Levels of racism illustrates 3 levels of racism and highlights the fact that if we want to set things right, we have to at least address the institutionalized racism. And life on a conveyor belt motivates us to act. I hope that you've understood these stories. I hope that you'll find them useful tools, and I hope that you carry them out into the world. Thank you very much.
So hopefully, having seen some of the allegories that Dr. Kamara Jones presents, you'll have a better understanding of how racism shows up in our work and why advancing health equity is very important. So now at this time, we'll actually start and continue our conversation looking at the health equity impact assessment.
So Tanya, thank you so much for setting the groundwork and the stage for why a health equity impact assessment can be a useful tool. I feel like it's one thing that we can say that, okay, we're on the conveyor belt now if we're using this tool, or at least I hope so. Tanya and Dr. Jones are always so inspirational to me, and I could hear them and listen to them day after day. So I'm so excited to have the Pechacucha talk that Tanya's done as a recording. So I really do think every morning I should just listen to that first thing. So turning to the tool, I've been fortunate to work with a group of dedicated DPH staff members and our partners from NC Child and the March of Dimes to create this tool. We initially created it back in 2018 based on work done originally by the Washington State Department of Public Health and the City of Seattle on their Race and Social Justice Initiative Racial Equity Toolkit, and we've been revising it ever since. And I realized that I failed to mention the Office of Minority Health and Health Disparities, which is really in the department. They are definitely one of the biggest partners. So what is the HIA? This tool provides a structured process to guide the development, implementation, and evaluation of policies and programs that we hope will promote health equity and ultimately reduce disparities. The tool itself consists of a series of worksheets, each building on the previous ones. The worksheets are intended to focus discussions and document proposals for modifications or changes to the policy or the program being assessed. Next slide. There are several applications for the health equity impact assessment, and with examining policies just being one of them. It can also be used to evaluate existing state or local programs or to develop new ones intended to ensure equitable outcomes. In addition, it can be used by community-based organizations to assess agency policies and as a leverage for collective impact. Next slide, please. So in order to ensure that our policies are equitable, we need to do at least these 3 things. We need to identify existing gaps so that policies can address them. We need to promote community-informed policymaking, and that means that we consider the needs of the impacted communities and really listen to those community voices. And then we also must measure impact, as we cannot know what we don't measure. And the HIA tool can help us with all 3 of these actions. Next slide. So one of the biggest requirements of using the HIA tool is to have some dedicated time. The day of the assessment itself, you need participants to agree to be there for at least 5 hours. It can be done over consecutive days, but this is harder to do and isn't optimal because you might have different people that are there on the different days and the conversations just can't be continued as easily. So you'll want to have a comfortable and accessible location, and if possible, have food. That always helps. If you have the luxury of working with a group that already is meeting regularly and you can provide some ongoing equity training to them prior to and then after the HIA, that can be useful. And then we'll talk about necessary data more in a moment, but if you have somebody who is familiar with sharing data, both quantitative and qualitative, that can assist you, that also can be helpful. And then as well, if you have a trained facilitator that can help with the implementation of the tool on the HIA day, that is also something to look for. So before you get to the implementation day of the HIA tool though, a small leadership team must work through the 3 pre-work steps that will help you identify your policy and implementation team, will perform a self-assessment and prepare the HIA team, and then they will also complete the data profile. The leadership team is a small group of people who come together to address a policy or program in their community that may be negatively affecting impacted communities and resulting in negative unintended consequences. This group is responsible for recruiting and engaging stakeholders, community experts, content experts, and providers, and others to become part of the implementation team. Once the implementation team is identified, it's good to spend some time providing opportunities for them to enhance their knowledge and skills associated with health equity, health disparities, and implicit biases. The Health Equity Impact Assessment Implementation Guide has a list of resources of videos and articles that should be shared with the members of the implementation team so that when they come together, they are better prepared and have some shared basic knowledge. Preparing the data profile is another important part of the pre-work. While the amount of data and the kind of data available will vary depending on the choice of the policy or program you're assessing, it's important that as much as possible, the data that's available is analyzed by race and ethnicity and other key demographic factors so that the health disparities and inequities can be identified more easily. Once the data to be shared is collected and analyzed, it is important to think through how to best share that data using charts, tables, and graphs that are easily understood. The better story you can tell with the data, the better the outcomes that of your HIA will be. So once you get to the actual implementation day, there's 4 steps to the process, and these will be completed jointly by your leadership team and the implementation team. The HIA implementation guide takes you through this process. In step 1, you'll ensure that all the team members understand the policy that's going to be assessed using the tool that day. In your second step, though, your team will develop a specific problem statement for that policy using your data profile as well as a root cause analysis of the problem to understand the true root causes or causes of the problem. In step 3, with the problem statement in hand, your team will determine what modifications need to be made to the policy to reduce the root causes that contribute to the health inequities. And then finally, in step 4, your team will develop an accountability plan to continue to monitor the impact of the policy, the modifications to the policy, and to ensure that the disparate impacts and negative unintended consequences are assessed and remediated or remedied. So when we look at the root causes of a problem, so once you've talked about the general policy or program in step 1, in step 2, you're going to review the data profile and more thoroughly analyze the most pertinent data that you have about the policy, again, broken down by race and ethnicity and other factors, to try to identify the underlying or root causes of the problem, creating any potential inequities. Root causes get to the heart of complex problems as they are the underlying reasons that create differences seen in health outcomes. They are the conditions in the community which determine whether people have access to the resources that they need to thrive. One way to determine root causes is to use the but why or 5 whys technique. This technique examines a problem by asking questions to find out what caused it. Each time an answer is given, a follow-up but why is asked. very similar to what small children do when they repeatedly ask why over and over, trying to understand something. To understand this technique and to learn more about root causes, we're going to watch the video, Why is Jason in the Hospital?, which was created by Martin Munoz and Matthew Kroskian and is based on a story from the Unnatural Causes video series.
Say hi, Andres. Andres wants to know why Jason is in the hospital with an infection. Because he has a cut on his leg. Because he was playing in an empty lot by his apartment building and got cut on an old car. Because his neighborhood is kind of run down. A lot of kids play there and there's no one there to watch them. Because his parents can't afford a nicer place to live. Even though both of his parents work, they have a hard time paying the bills. Even though his parents are very hard workers and even have multiple jobs, but they don't have a lot of education, so none of their jobs pays very much. They work so hard, there's very little time to be with Jason, even though they want to be.
Whatever happened to the values of humanity? Whatever happened to the fairness and equality? Instead of spreading love, we're spreading animosity. Lack of understanding leading us away from unity. That's the reason why sometimes I'm feeling under. That's the reason why sometimes I'm feeling down.
A lot of things affect Jason's health. There are a lot of topics in this story, and some may even seem unrelated to health. For an industrialized nation, the U.S. is one of the more unhealthy countries in the world. Health care is needed to treat Jason's infection. But community health deals with all the other issues. Safe built environment, ample social connectedness, access to good education, good paying jobs. We all deserve quality health care. But when will we, as adults, find the Andres within us and keep asking why? Why are so many of us getting so sick? Why are some communities much sicker than others? If we keep asking why, we'll focus more on keeping us all healthy instead of just treating illness. Treating Jason's infection is important, but focusing on why he got sick in the first place. Why doesn't he have a clean, safe park near his home? We call that part of his built environment. Why isn't an adult around to watch him? That is part of his social environment. Created by Bernalillo County Environmental Health, Bernalillo County Community Health Council, Bernalillo County Place Matters.
So I hope that video helped show the different types of root causes. It's another way of talking about the social determinants of health and how, our health is so much more than just the clinical health care that we seek. And that asking but why is so very important. And we do think that the health equity impact assessment is just one tool to help you do that. As I said earlier, we're always trying to improve this tool. It's been hard to find good resources to guide us about the effectiveness of the HIA, as there aren't a lot of similar tools that exist. That you can find health impact assessment tools all over, but these don't look specifically at the health outcomes of vulnerable populations, which we think is critical. And the HIA tools that do exist haven't been fully evaluated, and also they haven't been implemented systematically, which also makes it hard to measure their effectiveness. So, next slide, please. We have learned some lessons by asking some of the groups in North Carolina that have implemented the HIA tool, a series of questions and some focus groups. These are mostly local health department staff members that have used the tool. And we found out that practice does help. The HIA does get easier to use over time. So the first time doing it was quite scary for some of these projects, but the second time that they did it with a different policy or practice, it got easier. We know that to have a successful HIA, you must have the right people at the table, the right mix of community advocates, public health leaders, people in the affected populations, and experts in the policy or program that you're discussing. A benefit of the HIA is that the discussion is grounded in data. The better the story you can tell with the data, making it understandable and clear, the better the outcomes of the HIA. And lastly, and we're working on this to improve the tool, but the less jargon and technical terms you use, the better. You want everybody at the table to understand what is being said. So if you're interested in using the Health Equity Impact Assessment, the easiest place to find it is on NC Child's website on the Healthy Children page. You can find this page by clicking on what we do in the header on the main NC Child website. And then once you do that, the next slide, please. You scroll down to where you see the North Carolina Health Equity Impact Assessment box, and you can click on that to get the assessment tool. You'll be asked to complete a survey before being able to request the tool, as we are interested in learning who is using the tool and what type of experience they're having when they use it. One of the members of the North Carolina Office of Minority Health and Health Disparities tries to follow up via phone call or email about 6 months after someone has downloaded the tool, just to check in and see what we can learn. Also to note is that you can click on another link on this page to watch a webinar prepared by Vicki Krause, a policy analyst with NC Child, which goes into more detail about how to use the HIA tool. So I think that wraps up the content that we had to share with you today. If you have any questions about the assessment tool or anything else that was discussed, there's time for question and answers right now, but you can also reach out to Tanya or me or Whitney Tucker with NC Child, who's also on the Impact Equity NC team that is creating the HIA. So Tanya, I'll open it up for any questions that we might have.
Thank you so much, Tanya and Sarah. And I see we've got lots of questions in the chat, and hopefully folks have had a chance to answer those throughout the presentation. I know I saw a couple things popping up in the Q&A. And I know we only have 4 minutes left for today's presentation. So I really just want to take this opportunity to thank Tanya and Sarah. Thank all of you for attending. This is the last session of 2020 Kids, so this will conclude 2020 Kids. And before you sign off, I just want to remind you of the 3 actions that we've asked you to take to be a voice for kids today. For organizations who are interested in taking action, please note 2 of these steps need to be done by 5 p.m. today. First, the U.S. Senate has released its coronavirus relief proposal, the HEALS Act, and it does not begin to meet the needs of kids and families. So please join NC Child in calling on U.S. Senators Burr and Tillis to include vital provisions in the upcoming stimulus that were left out of the HEALS Act. And second, the Trump administration has announced it will be cutting the census short by 30 days. This is going to result in a massive undercount, particularly of the hard-to-count communities that the census concentrates on in its final push. If you need a reminder, a census undercount means that low-income communities in particular will not receive their fair share of federal funding or representation in Congress for the next decade. So please join us in making sure that all kids are counted in the 2020 census. Last but not least, you all know that the 2020 election is a critical time for our kids' futures. We hope that each of you will participate in voter education and voter engagement work. In order to build a better and more equitable future for our kids, we need elected officials who champion all North Carolina families. So we are putting a link in the chat box right now to link to all 3 of those actions. Thanks, Morgan. And you'll also be receiving an email from Lamine Perkins in just a few minutes. That email will have a link to those actions that we just described, as well as closing remarks, a link to the conference evaluation. So please do take a minute to fill out the evaluation. If you want to get a certificate of attendance, you will get that upon completing the evaluation. Also wanted just to note that every session at 2020 Kids was recorded, and everyone who registered will get a follow-up email from Lamine within the next 2 weeks with links to all of those recorded sessions from the conference. Those will be available in English and Spanish. Thank you all so much. I see a question. The evaluation will come out in a follow-up email from Lamine Perkins. So make sure that if you haven't been receiving emails from Lamine, make sure that you check your spam filter to be sure to get those. Thank you all so much. Thank you, Tanya. Thank you, Sarah. Wonderful presentation. Really enjoyed having you all here, and just really appreciate your partnership. And thank all of you for attending. So glad to be able to join you in this work. Take care. Happy Wednesday. Bye.